Hi there, I'm Sujata, founder of Grace USMLE Tutoring. I partnered with Achievable to create a comprehensive USMLE Step 1 course for medical students. It combines my years of USMLE tutoring experience with Achievable's powerful software. To learn more and gain access to a free trial, visit achievable.me.
Hello everyone, I am Sujata. In this video, I would like to talk about disorders of calcium metabolism. Calcium levels in our body are regulated in a very tight range, mainly by the effects of parathyroid hormone or PTH, vitamin D, and to a small extent by calcitonin. Disorders in calcium metabolism may lead to hypercalcemia or hypocalcemia. Causes of hypercalcemia includes hyperparathyroidism, vitamin D toxicity, paraneoplastic syndromes due to excess PTH-related peptide secretion, some other malignancies, and medications like thiazides, estrogens, etc. Hyperparathyroidism is one of the most common causes of hypercalcemia. It is simply excess PTH in the body. Depending upon what is the primary issue causing the excess PTH, hyperparathyroidism can be divided into three types: primary, secondary, and tertiary hyperparathyroidism. Hyperparathyroidism may be primary, secondary, or tertiary. In primary hyperparathyroidism, the defect is in the parathyroid gland. For example, it may be a parathyroid adenoma or it may be parathyroid gland hypertrophy. Sometimes it may be caused due to lithium toxicity. In secondary hyperparathyroidism, the cause is outside the parathyroid gland. More commonly, it may be a chronic renal failure which causes a vitamin D deficiency, or it may be a primary vitamin D deficiency or a low calcium intake. Tertiary hyperparathyroidism is seen most commonly in long-standing cases of chronic renal failure. The clinical features of hyperparathyroidism are due to the effects of hypercalcemia. It may present with abdominal pain, constipation, renal calculi, psychiatric or mental changes, anxiety, mood changes, or some specific features like calciphylaxis and osteitis fibrosa cystica. Calciphylaxis is a condition which is caused by clotting in the subcutaneous tissues of the body due to activation of clotting enzymes by the excess calcium in the blood. On the other hand, osteitis fibrosa cystica is a bone condition also called as brown tumors. It is not a malignant or pre-malignant condition. It occurs due to collection of hemorrhagic fluid within the bone, which is being lysed due to the extra PTH in the body. Let's look at the laboratory features in hyperparathyroidism. So while investigating hyperparathyroidism, we need to look at the levels of PTH, serum calcium, and serum phosphate. So irrespective of the cause, in all cases of hyperparathyroidism, the PTH in serum will always be elevated. So we are going to differentiate primary, secondary, and tertiary hyperparathyroidism by the serum calcium and serum phosphate levels. In primary hyperparathyroidism, the PTH is going to be high, which causes the serum calcium to be high and the serum phosphate to be low. So this is just a result of the excess PTH. On the other hand, in secondary hyperparathyroidism, the primary cause is a low serum calcium level, which in turn will cause the PTH to be elevated. The level of phosphate will actually depend on what is the cause of secondary hyperparathyroidism. If the cause is renal failure, then the phosphate will be elevated. If the cause is vitamin D deficiency, then the serum phosphate is going to be low. On the other hand, in tertiary hyperparathyroidism, the PTH again is elevated. The serum calcium is more likely to be normal. The serum phosphate is more likely to be normal, or sometimes it may be high, depending again on the cause. Some of the common causes of hypocalcemia include hypoparathyroidism, malnourishment, vitamin D deficiency or vitamin D receptor deficits, chronic liver disease, chronic kidney disease, certain medications like imatinib, biphosphonates, and disorders in magnesium. The clinical features of hypocalcemia include fatigue, tetany, paresthesias, muscle cramps, and some mental changes. There may be basal ganglia calcifications, especially in primary hypoparathyroidism. The QTc may be elevated. Some of the clinical signs that can be elicited is Vosteck sign and Trozos sign. Vosteck sign is elicited by tapping the facial nerve, which causes facial twitching and paresthesia in the distribution of the facial nerve. Trozos sign is elevated by inflating a blood pressure cuff in the mid-arm, which then results in carpopedal spasm. There are three types of hypoparathyroidism. The most common is primary hypoparathyroidism, followed by pseudo-hypoparathyroidism, and the last one, which is pseudo-hypoparathyroidism. The most common cause of primary hypoparathyroidism is iatrogenic, that is surgical excision of the parathyroid gland while doing thyroid surgery like a lobectomy or a partial thyroidectomy. Sometimes it may follow irradiation to the neck and thyroid gland. Sometimes it may be a part of polyglandular autoimmune syndromes, or it may be due to metastasis to the parathyroid gland, which may stop the functioning of the parathyroid gland, etc. Some congenital conditions, especially DiGeorge syndrome, can also be associated with primary hypoparathyroidism. Laboratory features include a low PTH level, which will then lead to a low calcium and a high serum phosphate level. Pseudo-hypoparathyroidism is also called as Albright's hereditary osteodystrophy. It is caused by a receptor defect of PTH. There is no problem in the parathyroid gland. The problem is in the receptor where parathyroid hormone acts at the tissue level. So what happens is the mutation is inherited from the mom in this case, and it leads to mental retardation and short fourth and fifth metacarpal bones, which can be seen clinically or on an X-ray of the hand. In pseudo-hypoparathyroidism, it is an autosomal dominant disorder that is inherited from the father, and it shows mutations in the GNAS gene. There is no resistance to the effect of PTH in comparison to pseudo-hypoparathyroidism. The clinical features include mental retardation or learning disabilities, a short fourth or fifth metacarpal bone, just like in pseudo-hypoparathyroidism, a round or moon face, and short stature. The laboratory findings in both types of pseudo-hypoparathyroidism may show varying levels of PTH, serum calcium, and serum phosphate. More often, the PTH is normal or high rather than low. The serum calcium is normal or it may be low, and the serum phosphate is more likely to be elevated. Hope this video clarified some of your concepts on hypercalcemia, hypocalcemia, and disorders of calcium metabolism. Thanks for watching.